It's my pleasure to introduce Dr. McGrath Morrow, Sharon, and I'm just going to give you some background about her. She's really remarkable. We're very lucky to have been able to recruit her here. She's the Associate Chief of the Division of Pulmonary and Sleep Medicine, and she's also the leader of the post-preemie, meaning those babies who were born early, who develop lung disease later after infancy, here at CHOP. And she's conducted a lot of very, very interesting and important research that links what happens early in life with outcomes much later in life. So we think about kids who graduate from the NICU, from our intensive care nursery at CHOP, from the hospital, go home, we think they're fine, but actually the stage is set and there's lots of problems that develop later in life. She's been funded by the NIH for a long, long, long time. And her clinical research, as I mentioned, is focused on premature babies who have chronic lung disease and pulmonary hypertension. She's the executive and founding member of the BPD Collaborative. So meaning that's a disease that babies who are born premature and have undeveloped lungs develop and can cause significant morbidity as well as death. She's also the principal investigator for the American Academy of Pediatrics, the Julius Richmond Center of Excellence, which is committed to protecting children from the health effects of secondhand smoke through both research and advocacy. And she is our thematic leader of the air pollution and lung health section of the Center for Excellence in Environmental Toxicology here at Penn, as well as being an integral part of our Children's Center. So with that, I would like to welcome Sharon.
So thank you, Becky, for that introduction. And although I do very much enjoy taking care of children who are born premature, I also see a lot of children with asthma. And as Becky said, I'm a pediatric pulmonologist at CHOP. And today I'm going to be talking about communicating asthma prevention to patients, which I think is a really, really important topic. So the objectives of my talk are really to summarize, somewhat briefly, the burden of asthma in the United States. This is a chronic lung disease. We have no cure for it, and it really causes a lot of burden for both children and adults, really globally. I want to specifically discuss the importance of patient caregiver education in improving asthma outcomes and some of the things that we need to discuss with our patients, particularly communicating the understanding of asthma pathophysiology to our patients and caregivers, asthma prevention and treatment and proper use of medications. I'm going to discuss how communication can promote partnering with patients and caregivers to really encourage self-management. So the key of all this is, asthma really is self-management. We see patients briefly, in the inpatient, hopefully not so much in the inpatient, but in the outpatient world. And it's really their ability to self-manage their asthma, which can really improve asthma outcomes. And then really discuss the importance of shared decision-making and improving asthma outcomes by addressing barriers such as medication use and adherence. So what is the prevalence of asthma? And since I'm a pediatric pulmonologist, I primarily focus on children and adolescents. Asthma affects about 8.5% or 8.4% of children in the United States. And there are approximately 80,000 hospitalizations each year in the US due to asthma exacerbations, and another 550,000 emergency department visits each year among children. There is some regional variation in asthma prevalence across the United States. In the Northeast, we have, about 722,000 children with asthma and about 2.5 million adults with asthma. Down south actually has the highest prevalence of asthma, both in children and in adults. So this is just some data that I pulled from the CDC, and I thought this was really interesting. It's looking at asthma prevalence between 2016 and 2018, and it's looking at prevalence by age, by sex, by race, ethnicity, and poverty level. And as you can see, which is kind of interesting, is that females actually have the highest prevalence of asthma, and we'll see how that changes with age. Really, our Black non-Hispanic population has a high prevalence of asthma, as does our multi-race non-Hispanic population. Our Hispanic Puerto Rican population has a very high prevalence of asthma compared to the other groups. And then not unexpectedly, if you're below 100% of the federal poverty level, you have the highest prevalence of asthma. What about asthma attack prevalence in the United States? Well, in the US, it's highest in our youngest children, which isn't a huge surprise to pediatricians. It's really the age group 0 to 4 years. It's high, fairly high in all the others, but it really sticks out that it's the youngest group that has the highest asthma attack prevalence. And then once again, prevalence of emergency department visits and urgent care visits for asthma is highest in our children between 0 and 4 years of age. And it's also, if you look at percent of the federal poverty level, it's highest in our poorest individuals. It's hard to know whether or not it's because they're having trouble with access to care, or if they're more likely to use the emergency room or urgent care visits for their treatment of asthma. But when we look at asthma mortality, I thought this was really interesting. Asthma mortality overall, and this is including both children and adults, is highest in our females compared to our males, and it's highest in people over 65, and it's highest in our Black non-Hispanic population. So these are really the populations that are at highest risk for asthma death. So when we look at asthma deaths in the US by sex and age, we see that from about it's relatively low in terms of our younger population. If we're looking at deaths rate per 100,000, although if we look at males versus females between less than 1 and 34 years of age, it's higher in males than in females. After age 35, however, it flips and we start seeing a higher asthma death rate in our females, and it's highest in our older individuals, really starting around 65 and older, with the highest asthma death rates in the US. So, one of the big questions is, how do we minimize this great morbidity and mortality from asthma? When we know that probably clinician care alone is not sufficient to achieve control of asthma, we spend a lot of time, putting together asthma action plans, talking to our patients, but we alone really can't do this. Asthma really requires a partnership. But we do need to provide enough education, and we need to communicate this in an effective manner to really help with optimizing our outcomes. And we know that asthma education can promote self-management practices. As you can see here, here's a mom who's correctly giving her child her asthma medication. She's using a spacer, which is really important. We know that without the use of spacers, we probably are only getting half of the medication. And we think overall, if a parent or a patient is willing to really embrace these self-management practices, we're going to have better asthma control. So what is it that a patient and caregiver should understand? I think it's really important for them to understand what medications are needed for asthma control. Very often when I'm in clinic, I'll ask them to bring their medications, and I'll say, which medication do you take every day? And they'll pull out a medication, and I'll say, and it may be actually the rescue medication. And I'd say, well, which one is your controller medication? Well, I'm not really sure. I know that this medication makes me feel better. So I'm not communicating well what medication is needed for asthma control. And for that reason, we really need to communicate why these medications are needed. The other thing is, when should these medications be given? A lot of times people don't caregivers or patients feel if they're feeling really well, that they don't need to use their maintenance or controller medications. How should they be given? We talked about using a spacer. What's the best way to deliver medication so it effectively goes into the lungs where asthma is affecting their breathing? What triggers their asthma symptoms? Some people have very decreased perception of their asthma symptoms. And so we'll talk about that a little bit later, how to recognize asthma symptoms and how to treat asthma attacks. So we know that if the patient and the caregiver really uses self-management, that's going to really overall improve their quality of life. It can improve symptom control, improve activity tolerance, particularly in active children. And if they're feeling better, it may actually improve medication adherence. And it should result in fewer urgent care visits, hospitalization, and overall reduced asthma-related cost. So what should asthma education really focus on? And these are really the 3 primary areas that we should think about. It's really important to educate our families, our patients, and our caregivers on the pathophysiology of asthma. A lot of times, people will ask, what is asthma? Why do I have to treat it? Is it going to go away? How are you going to diagnose this? We'll also talk a little bit about prevention and treatment of symptoms, and then function and appropriate use of medications. This is just a schematic of a lung, and on the left side we have our airways and our terminal bronchioles and our alveoli. So when we think about the lungs, I always tell my patients it's like an upside down tree. You start with the trunk, which is the trachea, and then you get smaller and smaller branches. And these branches, most of the branches make up the conducting airways. And the smallest conducting airways, or the small airways, are really where asthma is. Asthma is a disease of the small airways. It's not a disease of the large airways. And so that's why it's so important, for instance, to use the spacer so you can get deposition into these very, very small airways. And asthma is also a disease of inflammation. And this helps kind of explain why these controller medications, such as our inhaled corticosteroids, are so important for controlling asthma. And this is a nice little figure from the GINA patient handbook from 2021, which shows on the left side, when asthma is controlled, airways are open and clear. And when with an asthma attack, airways are swollen with increased mucus. And I always have like a poster in my outpatient room to sort of kind of go over this. I always go over the analogy of the tree and the small airways, and then just showing how the small airways will close down and how it's very, very difficult to breathe once they're closed down. And it kind of gives people a kind of a way of kind of understanding what's happening to their breathing. I think it's also really important to really discuss how asthma is diagnosed. A lot of times families will come, or patients will come, and they'll say, I don't really think I have asthma. Can I have that blood test to tell me whether I have asthma or not? And there really isn't a great test for asthma. Asthma primarily is diagnosed based on clinical symptoms. And in young children, it really is pretty exclusively diagnosed by history and physical examination. And as most of you probably know, the clinical symptoms can include recurrent episodes of coughing or wheezing. It doesn't have to be wheezing. Everybody always thinks that asthma is wheezing primarily, but particularly in our young kids, it's often recurrent episodes of coughing. After a viral infection, normally you would expect a viral infection to clear up between 3 and 7 days, and these children will be coughing for weeks and weeks after a viral infection, which is the most common trigger in that age group. Some children or people with asthma will complain of breathlessness. Our adolescents often will talk about chest tightness, pressure, and chest pain. 80% of children with asthma develop symptoms before 5 years of age, and the diagnosis, as I was kind of alluding to, is often missed or not suspected, particularly in our infants and toddlers. In older school-age children and adolescents with suspected asthma, spirometry should also be performed, and that can be really, really helpful. We do, at least at our first visit, we'll do pre and post bronchodilator spirometry. And it'll often show reversible airflow obstruction. So if we look specifically at our forced expiratory volume in 1 second, we expect that if they have a positive response to bronchodilators, we'll see a change in about 10% or more. Keep in mind that in children, often if you just do pre-spirometry or only just do simple spirometry without the bronchodilator, the lung function may be normal because children often will have very normal lungs, unlike adults who have long-standing asthma. And so the post bronchodilator is really important to see whether or not they have airway reactivity. Also, resting spirometry may be normal in children with well-controlled asthma. You don't expect to have reversible airflow obstruction if you're well controlled with your asthma. And in those with exercise-induced asthma, you may not see airflow obstruction unless you exercise them. And resting spirometry, by definition, is done at rest, and so you may not see that. So what about education for prevention and treatment of symptoms? So it's really important to discuss the common asthma triggers, and some of the very common triggers are, secondhand smoke. We always ask, are these children or adults exposed to secondhand smoke? Often they'll say no, but then when you get down to it, people may say, well, I smoke outside the home. We know that that the smoke and the chemicals from secondhand smoke and primary smoke can settle on clothes, and that can be a problem if people who have been smoking come in, and that can also irritate the airways to somebody who's susceptible. Cats and dog dander, exercise, pollen. In some of our city, especially people who live in row houses in the city, there's problems with cockroaches, and cockroach allergen is very, very common, along with rodent allergens. Exposure to perfumes in children, the primary insult or trigger is respiratory viruses, and then changes in weather and stress. There's a lot of new information looking at just stress, particularly caused by violence in neighborhoods, and that can be associated with poor control of asthma. So, why do we discuss preventative medications? And I think it's really important to try to convey to patients and caregivers the importance of preventative medication, because there's a lot of ideas out there. It's important to really try to explain that it reduces swelling of the airways. Some of the beliefs are that preventative medications become less effective with time, and that's not true. So it's really important to explain that these medications, such as our inhaled corticosteroids and our combination medications, do not become less effective. They stay just as effective if you use them every day, or if you use them intermittently. And you can't become addicted to preventive medications. And then who should use a preventive medication? Not everybody necessarily needs it. If children or adults are just having very rarely asthma symptoms, then a rescue medication may be good enough. But if you cough or wheeze or have chest tightness more than twice a week, if you wake up at night because of asthma, if you have many asthma attacks, and if you have to use the quick relief medicine, such as albuterol, more than twice a week to stop asthma attacks, those are the population that really should be using preventive medications. It's really important to create a partnership between the clinician or healthcare provider and the patient or caregiver. The first thing you would do is really identify relevant indoor allergens for mitigation, discuss whether the use of a maintenance medication is indicated, and in appropriate select groups, particularly our teenagers, you may consider implementation of SMART therapy or single maintenance and reliever therapy. And that is using a combination budesonide formoterol inhaler, which was first really used in Europe and in Australia. And we're starting to really use this a lot. And this actually can help with better asthma control, particularly in our older children and adolescents. So how do you discuss identifying asthma attacks and how to monitor asthma control? Obviously, patients need to be able to recognize symptoms of an asthma attack, but really, even more importantly, symptoms that may precede an asthma attack. And that may be, and this is something that needs to really be discussed because, children are active, adolescents, are doing a lot of activities in school, and they may not actually recognize symptoms that may precede an asthma attack, which may include increasing shortness of breath with activities. They may be playing out on the field and they're just not able to catch their breath as well. And they may not actually be able to distinguish whether they're just fatigued from overexercising or if this is preceding an asthma attack. Cold symptoms, including cough, throat clearing, rhinorrhea can precede an asthma attack, and then even some subtle chest pain or tightness. So it's really important to kind of have people recognize symptoms that may precede an attack, and then discuss symptoms of attack, and then what to do with an asthma attack. So this is another little picture from the patient guide from GINA guide in 2021, and it's just kind of nice. I think it's always really good to have illustrations, not just words, and this is for children. Be alert for your asthma symptoms, act fast if an asthma attack starts, move away from the trigger, which is really important. Some children, if parents are smoking, if there's cats and dogs and they're triggered, it's very difficult for them to move away from that trigger. But that's really important to remind people that that's one of the first things you do. Take a quick relief asthma medication and try to stay calm. Being calm with an asthma attack is super important. I've actually seen children who got very, very upset. Their asthma got worse and worse and worse. And, just actually having a mom get in bed with a child and calming them down can really break an asthma attack. Obviously, that's not what we want to have to do. We don't want to get to that point, but that can be very important, staying calm during an asthma attack. Okay, so what about asthma action plans? Well, I believe that everybody should have an individualized asthma action plan, but the point is it has to be individualized. Asthma action plans in general can be useful in explaining medication plans and offering guidance for adjusting asthma treatment when you have changes in asthma symptoms. It's important to remember that it should be simple and it needs to be easy to read for all levels of literacy. And so there probably should be pictures, there should be not a lot of text, it should be as simple as possible. And then the other thing to remember is that the asthma action plan should be frequently reviewed and updated as needed. So what are some examples of action plans? I just kind of pulled this one off. This is a very kind of nice, simple asthma action plan. It can incorporate peak flow meters if you're using that to manage control of your asthma, but it also looks at clinical symptoms. So, all of us probably have heard of the green zone, the yellow zone, and the red zone. And so in the first part on the left side, it really talks about, we're not having any coughing or wheezing. These are the daily medications we should be taking. This is how much we should be taking, and this is when we should be taking it. And then we go down into the yellow zone, we're starting to have some symptoms. We need to add a quick relief medicine. It tells you the number of puffs and how frequently you can repeat it. And then you do this until you get back to your green zone or you advance to your red zone. And then on the red zone, it describes some of the symptoms, taking the medications, the puffs, the nebulizers, and when to go to the hospital or to call an ambulance. So this can be really, really helpful, but it's really important. I think a lot of us really, we're busy in clinic and we don't always go through the asthma action plan with our patients, or we just kind of write it up and we just kind of throw it at them. I think it's really important to make sure that people really understand, what this document means. These are two other asthma action plans. The one on the left-hand side is for kids over the age of 5. It really incorporates peak flows, your peak flow in the green zone, the yellow zone, and the red zone. And peak flows are really helpful for people who are poor perceivers of their breathing. On the right-hand side is a child asthma action plan for kids from 0 to 5. And it's really based on symptoms and, no asthma symptoms, very active during play, the yellow zone, playing less than usual, the red zone, wheezing, coughing, difficulty breathing, and then when to get help. So in theory, an individualized asthma plan is great, but there are definitely benefits to having an individualized asthma plan, but there also are some barriers. We can be giving these out and we think they're working great when they really aren't working well. So they need to be really patient-centered, and they need to be built on a partnership. So it's really important to communicate to your families what this document is. It's really important with your patient or caregiver to discuss their own personal asthma strategies, because they're the ones living with this asthma. And you could put this down and they may say, this isn't what I'm going to do, and so it really needs to sort of be this back and forth discussion. Essentially, there needs to be a balance between this patient autonomy or caregiver autonomy and then your professional responsibility to your patient. You can be the best provider in the world, but if your patient isn't really listening to you, then it's really you're not going to have good outcomes. It needs to be customized, and you sometimes have to jointly negotiate, what you're going to do. And it may not be perfect. You may have to change things around because, if you have a good open communication with your patient or caregiver, they're going to tell you what they can do and what they can't do. You should really frequently review it at each visit and make adjustments, because the experiences that a patient and caregiver have at diagnosis with asthma is very different than what their experiences are, 5 or 10 years into their asthma diagnosis. And so that may change. You often will need to address the broader issues of living with a long-term condition. And it can very often fail if the patient and caregiver's perception of asthma management is different than the clinician or healthcare provider. So what about flow meters in the management of peak flow meters in the management of asthma? They can be useful, but they're particularly useful in patients who have poor perception of asthma symptoms. So if you have somebody who really has good perception, you don't need to necessarily burden them with a peak flow meter. However, it's most useful in people with poor perception of asthma symptoms. And essentially what you do is you determine your individual personal best peak flow, and it's usually between 80 and 100% of the personal best. But the other thing that's really important to understand is, even though these can be useful, they're only as good as the maximal effort that the child or the adult puts into using it. So if somebody is just kind of like, I really don't want to do this, and they give a very suboptimal effort, you're not going to have a good number, and you're not going to really be able to use your peak flow to really guide, treatment, of the asthma. So it's really important for whoever uses the peak flow meters to have a good technique and to use it, regularly, so that you know what your normal range is, because that's going to change over time and with age. So what about function and appropriate use of medication? We have lots of medications for asthma, but a lot of them aren't being used, or they're not being used correctly. And really, one of the major things that we use for treatment of asthma or maintenance of asthma is our inhaled corticosteroids and our beta agonists. And as you can see, this is a little guy. What's the matter with this picture? This is a little guy who is administering his asthma medication himself. He's got it kind of stuck in his mouth. Who knows what he's doing with it? This is a little guy who should have a spacer, probably a face mask, and should be having somebody who's helping him administer the inhaler. I can't tell you, I just had a 3-year-old who came into my clinic, and the mom says, "Oh, he does it by himself." And I said, "Well, where's your spacer?" "Oh, we don't need to use that." And so we had to go through the education, because the likelihood of that child getting the medication was very, very low. So there are very, very high rates of incorrect inhaler use, not only in young children, but in older children and adults. So regular and repeated inhaler education is really critical to support better asthma outcomes. More than half of children who use MDIs without devices such as spacers and valve holding chambers, and these are the ones, as I said before, will probably gain little or no clinical benefit from their inhaled medication. Some of the older children, the adolescents and adults, actually can probably get away with now using a spacer if they're doing it correctly. But even in that age group, most of them would benefit from a spacer with their inhaler. So, how do you do it? You really should review inhaler technique. After you start an inhaler, you should review the technique within 4 to 6 weeks of introducing a new device. And then it's essential that they really perform the technique, probably at every visit, just to make sure that your patient is really adequately getting medication into the lungs. And here we have our spacer, and this is one that's very commonly used. This is an older child, so she doesn't need a face mask. She can use a mouthpiece. So this is, I thought, was a nice little thing to remember, the 3 C's of inhaler use. Choose the most appropriate device. Think about whether or not this patient has some limitations. A child might be 12, but if they have cerebral palsy and they're going to need help, you should probably use a face mask rather than a mouthpiece. Check the inhaler technique at every opportunity and correct them using a physical demonstration, 2 to 3 times, if necessary, to make sure that they really know how to use an inhaler. So this is just patient education booklet. This is from Gina, and it's you can get this online. It's a really nice patient guide. It's translated into quite a few languages: Chinese, German, French, Spanish, Swedish, and Turkish. And I think it's a very useful guide for patients and caregivers in terms of helping with asthma control. So as I said before, asthma education needs to be coupled with shared decision-making and self-management. It really is this shared decision-making that's really going to help with asthma control and compliance. The CDC reported that 44% of children and 60% of adults have poorly controlled asthma. And the reason for this is lack of adherence to treatment recommendations, poor inhaler technique, concerns about safety and efficacy of inhaled corticosteroids, which is really important to discuss with your patients and families. A lot of people will rely on the short-acting beta agonists because that's a quick fix that makes them feel better. The maintenance or controller medications, they may not feel like that is doing anything for them. And really shared decision-making is really encouraged by these national organizations for asthma. So what about shared decision-making? Shared decision-making and self-management can really improve asthma control. So you want to always involve the patient and caregiver in shared decision-making. There's always a tendency, like particularly in our older children and adolescents, when they come with their caregiver or their parent, a lot of times we talk to their caregiver and their parent, but it's really the child that's really doing all the asthma, therapies. And so it's really, really important to talk to that child. And you really want to encourage them, in their self-management skills and efforts. If it's a school-age child with asthma, the school health system should be involved. And it's really important to foster this trusting relationship so that these barriers for successful self-management can be discussed. You really need to ask openly about patient preferences and goals and incorporate these treatments when possible. And really importantly, you need to ask patients and families about their concerns and fears, because they're not going to necessarily bring them up. A lot of families are very concerned about asthma as a chronic illness. They just want it to go away. They're worried about the medication use, either side effects or dependency. They're hearing different things from different family members and friends. And a lot of times they won't tell you that the costs are really awful, that the copays are very high. And it may be that you can change the medication so that the copays aren't as high, but you're not going to know that unless you have that discussion. You need to openly discuss mutual goals for good asthma control, and some of our goals, and I think when you actually talk about the goals, families may have more buy-in: freedom from frequent or troublesome symptoms, fewer nighttime awakenings. We want to optimize lung function. You want them to be able to maintain their daily activities, including athletics, and really satisfaction with asthma care. You don't want to overburden them with too many treatments during the day, if possible. And then it's really important to discuss the importance of minimizing future risk, because we know that, people over time can develop suboptimal lung function and early onset chronic obstructive pulmonary disease from childhood asthma if it's poorly controlled. Sometimes if they're not taking their controller medications, they're frequently on oral corticosteroids, which can cause side effects, including cataracts and other problems. And obviously, you want to prevent recurrent exacerbations, ER visits, and hospital care. So it's really, really important to kind of incorporate personal goals and decision-making into asthma management. So these are just some of the topics that should be discussed at the first visit, and they really take into account from the very, very beginning shared decision-making and self-management skills. You can ask people about what their goals of treatment are, what worries you most about asthma, what do you want to accomplish at this visit, have you tried medications before? You want to give them information about what is asthma, what are the treatments available, and then you want to teach and demonstrate skills such as inhaler and spacer technique, talk about the asthma action plan, and really, once again, simple written self-management plan. So these are all really important things to discuss at the first visit, so that you get on the right, standing with your patients and your caregivers. Once again, frequency of medication use, you want to discuss the expectations for asthma control, potential side effects, barriers to adherence, and avoid really embarrassing or shaming the patient or caregiver, because there may be cost or scheduling issues that really create barriers for them to take the medication. Future plans to adjust medications. So there's always this tendency to keep piling on medications, but you need to have a plan to take down medications, and everybody needs to be in agreement with that. And then this shared agreement for the best asthma action plan at that particular time. So what about access to medication in schools? Well, there are some, this is like what you want. Oh, sorry. This is what you want for an asthma-friendly school. You want a school that can identify and monitor all students with asthma. You want all children to have an individualized asthma action plan. Educate all the school personnel. Hopefully they have a registered nurse in every school, and that ensuring that students with asthma who are not well controlled are trained and provided with self-management education, and potentially having their quick relief medication with them. These are across the country. Access to medications in schools is very variable. Most of the states, there's no requirement. Some states require students to demonstrate use to a school nurse, such as Pennsylvania. Other states require a health provider demonstration, but not a school nurse. So it's all over the place. So it's really important to understand what kind of communication the family has with the school. But all of them, these are really these are really all the requirements, authorization from a child or parent to self-carry, permission from the child's healthcare provider with details of the prescribed medication, a written treatment plan, students' ability to demonstrate asthma management knowledge and skills, and then liability protection for the school and school personnel. So once again, it's really important to discuss the concerns about asthma or asthma treatment. This was an interesting study in which they looked at in-person focus groups in 3 cities across the United States. And what they found was that few patients or caregivers felt adequately informed about asthma medications or sufficiently involved in decisions about the treatment. And this was regardless of where they live, socioeconomic status, or clinical status of their asthma. Concerns were also voiced about device characteristics, the potential for side effects, and then the overall cost of asthma treatments. More Black and Hispanic participants and those with low income endorsed health literacy as a barrier. A lot of times they felt like they were filling out documents, understanding written materials were really a barrier for their asthma control. Participants with low income were less likely to even have an asthma action control plan, 42 versus 53 of higher income, and they were less likely to discuss asthma control with their healthcare provider. Black and Hispanic participants were more likely to have an emergency department visit or hospitalization for asthma within the last 12 months compared to to other participants or white participants. And these are just some. Here we have, so this really looks at some of the social determinants of the burden of asthma and how it varies. If you're white, you're less likely to have a hospitalization. If you're higher income, you're less likely to have an ER urgent care visit. And then there's additional challenges, including insurance issues and complexity of some of our newer controller medications, such as our biologics. Talk about the choice of controller medications. They change all the time because formularies keep changing. And so you may be training a patient or giving them information on one type of inhaler. And then 6 months later, the insurance companies may have another. And then with the biologics are a really interesting group of controller medications that more and more patients, particularly those with severe asthma, are starting to use. And there really are about 6 of them that are available now for the different age groups. However, it's been difficult understanding which insurances are going to pay for which biologics. And so that has also been a concern in terms of treatment. So just my final slide, which I'll just read, is that some of our take-home messages is that prevalence of asthma is high in the US and adherence to maintenance or controller medications is poor. Education, clear communication, shared decision-making, and self-management is really needed to achieve asthma control. An individualized asthma plan should be developed based on shared decision-making and updated as mutually agreed on. And education on the use of medications, particularly inhalers, should be frequently addressed. So thank you very much for letting me talk about something that I'm very passionate about, and I'm really happy to take any questions. Thank you.
Thanks, Sharon. That was amazing. Using this approach, have you all been able to look at sort of metrics as to how successful and that this can be continued? I mean, I know you have metrics in terms of looking at hospitalizations, et cetera, but have you thought about looking at using this approach at sort of a more lower resourced area, health system, et cetera, and can you extrapolate?
Yeah, I think there's a lot of evidence showing that. I mean, in theory, asthma action plans are wonderful. In reality, they work some of the time. And you really, I think just kind of in terms of my patient population, I think, maybe 30, 40 years ago, we had a very paternalistic society, and where the physician or healthcare provider would say, you need to do this, and people just kind of did it, whether it was good or bad or whatever. But I think now people are definitely more engaged in their health, and they really want to understand. And it really doesn't matter what level of socioeconomic you are. I mean, everybody, has availability to the internet. Everybody has social network, and they're going to hear opinions. And so it's super important. I found that this is true over the years, regardless of whether I'm treating asthma or children with bronchopulmonary dysplasia. Having that trust with the caregiver or the patient is just really critical. And it may be that, particularly in the beginning, you need to see them more frequently. You may have to spend more than 10 or 15 minutes with them, because this kind of education takes a while. It needs to be reinforced. And people may only hear the, one part of the message at the first visit, and then at the second visit, a second part of the message. And then they'll start, you'll start actually understanding what some of the barriers are. A barrier may be that I don't live close to a pharmacy, I have to work all the time, and the grandmother's taking care of the child and doesn't like to give them this particular medication, or they smoke and I don't have any other way of, and so really communication is probably the best way to get the best asthma control in patient population. And then other people have beliefs that there's no way they're going to use inhaled corticosteroids every day. And so you have to negotiate. Okay, we're going to start the use of inhaled corticosteroids at the first sign of an asthma symptom. And then we're going to use it for the duration of those symptoms. And then you can stop again, and then they're like, okay, I can do that. I'm all right with that, and then over time, they'll come back and say, yeah, that kind of worked. I like that approach, And so it's all about partnership and communication and education.
We know that there are a lot of other environmental contributors inside homes, such as cleaning products and personal care products. How do you talk with families about considering those things, recognizing that some of them are really, very near and dear to their heart, and might be, difficult to change?
It's really, you start with letting them recognize that these might be problems, because most people when you talk about the home, the indoor environment, it's kind of a touchy issue, because I almost always, I clean every day, and I might say, well, that's great that you clean every day. You probably don't want to clean in front of your child with asthma, though, because, even though it's very important to keep the environment clean, it may aerosolize things that can irritate their airways. And so you sort of start talking about it in ways that aren't directly, feeling that somebody has to defend themselves, why they're using or why they're doing a certain thing in their home. The other thing that I found was, particularly in urban settings, there's issues with rodents, and a lot of times a neighbor will have a mouse issue or a rodent issue, and there's not much that the family can do about that, because they're going to go from row house to row house. And so they'll have cats. And this will be a kid who's very allergic, and they're allergic to cats, but you're like, how do you, how do you deal with that? Because they have the cat because the cat will kill the rodents, and they really don't have another way of really dealing with the issue. And so these are, we talk about it, sometimes, there are certainly different things in the community, resources in the community, but they can only go so far. It's not like we can relocate everybody. And so some of these issues you just have to deal with and accept to a certain extent.
Sharon, this is a great, actually really comprehensive. That seems like we have a knowledge and a perception gap between what what you see, versus like everyday population, like general public. So this is a translational center. How does the center can help in terms of like get the message out to the general public, in terms of like for them to understand the consequences if you don't really control asthma well, or you don't remove some of the triggers at home. So this is something we can, certainly it's not really a quick answer, but I was just wanted to think what you can think of the way to really extend this knowledge and perception to the more wider public actually.
Yeah, I think it's really important to sort of have discussions like this. I think actually talking to the families and really understanding their barriers are going to make the healthcare providers better, because we have lots of educational material out there. It's just sort of really being able to make it such that people will actually read it, people will actually listen, put it, how do we, disseminate this material in a way that really is something that people are going to listen to, maybe we should put it on TikTok. I don't know. But I think there's also, whether you like it or not, there's people who are more influential than even, you're the doctor or whoever they're, people who really will talk about it, their experiences. So, I mean, I wish, I really wish I could give people a pill for their asthma, but unfortunately it's a chronic, often lifelong disease, and it does require, interventions that people don't always want to do, and so I don't know really what the best answer is to that, other than to just keep talking about it and really try to, really let people know that we're open to negotiation in the treatment of asthma, not, and that one size doesn't fit all. I mean, everything, we're so algorithm based now, whether it's a child comes in for bronchiolitis or asthma or whatever, everybody looks at an algorithm. And the reality is that these are really, disease, everybody's a little bit different, and it should be more personalized care and shared decision making in the treatment of these chronic diseases such as asthma.
Thank you, Sharon. That was really, really good.